Okay, we are being recorded.
Welcome, everyone, and thank you so much for joining us over this lunch hour for a What's New in Addiction Nursing presentation. My name is Emma Garrett, and I'm co-director of the Addiction Nursing Fellowship. I'm calling in from home today on the unceded lands of the Musqueam, Squamish, and Tsleil-Waututh. And I am very pleased to introduce Adam Pratt, who's put together an interesting presentation for us today, which he'll introduce. So Adam is both a registered nurse and a registered therapist, a former emergency nurse turned community mental health advocate. Adam has worked for Indigenous communities across BC, Manitoba, and Ontario over the last decade as a community health nurse and a mental health clinician. So over to you, Adam.
Thank you, Emma, Nadu, Miigwech. Yeah, I am Adam Pratt. I am a addiction nurse fellow. I'm going to take a moment and just locate myself. Fortunately, I can't do this in person with everyone today. I'm recovering from a small surgery here in my home in Didida, which is on the unceded traditional territories of the Pachidat people on Vancouver Island, also known as Jordan River. And I'm here to talk about semaglutides, Ozempics, Wegovy's, GLP-1s, talk about all that. So yeah, it's pretty informal. If anyone has any questions or comments, I'm going to rely on Emma or Amir to field that, and we'll start the show. So the title is called The Semaglutide Debate, Breakthrough in Addiction, or Just Hype. We'll come back to that. As I just mentioned, I'm calling in today from Didida. I have been raised in a settler family, and I spent the last decade as an ally and friend to various communities across Turtle Island, specifically to name a few, the Tall Tan people of northwestern BC, who I still work and play with. They're a large part of my heart. And then more recently with the Pachidat people here, Vancouver Island. I've also worked across probably 20 other communities of various sizes and shapes in BC, Manitoba, and a little bit in Ontario. That's kind of where my heart is. My background before that was I was a frontline emergency nurse. I did psychiatric nursing. I did cardiac nursing. I've done all sorts of different things and then pivoted into community health, later into mental health as a registered therapist, where I do addictions and trauma care. And I am more recently also offering consultation with some nations around creating land-based addiction medicine programs. So today, I have no conflict of interest to report in this presentation. And my objective today is to just chat a little bit about semaglutide's mechanism of action, or what we think mechanism of action is, the theoretical effects on the addiction pathways, talk about a couple of the interesting articles that have been circulating in the last year or two, see and discuss if this is a potential treatment or if we need more research. Interestingly enough, just before I jumped on this presentation, I just looked up Apple Podcasts. I think it was GLP-1 and addiction. I got like 25, maybe that's an exaggeration, 15 at least, different podcasts of probably a variety of value and intellectual rigor. There's also quite a bit of buzz in the internet around it for eating disorders, amongst other things. So I think most of us associate GLP-1s with diabetes and obesity management, but there is quite a few RCTs being churned out right now around it. The general media will often talk about it as a sort of wonder drug, but we'll dig into that a bit more. So the outline is an overview of the receptor agonists and their established roles. We'll talk a little bit about those mechanisms of actions, related literature, any clinical implications if there are, and if anyone has any questions at the end or want to discuss further, that's always a rich place where I like to dive in. So let me adjust my screen here. Forgive me. There we go. I think it goes without saying that alcohol use disorder is a significant burden on society and the health of individuals as well, and their communities that those people belong to. I think I myself come from a family with multiple generations of alcohol use disorder. And I'm also self-identified as somebody who lives in recovery. So I think there's quite a few lives that have been cut short as a result of alcohol use, especially in Canada where it's still quite normalized. These are just some brief little examples of some of the data. So, data from the 2021 Canadian Community Health Survey indicated that about 18% of people aged 15 years or older in Canada meet the clinical criteria for alcohol use disorder at some point in their lifetime. And that doesn't differentiate between like a mild, moderate, or severe alcohol use disorder, but that's still, I think, cause for concern. The other biggest piece that brings us to discuss the GLP-1s and novel pharmacotherapy today is up until, since 1951, I believe, when disulfiram came out, there's really only been two other approved treatments for alcohol use disorder in the US and in Canada. So that's disulfiram, acamprosate, naltrexone. And something that's another interesting sort of bit of information is that although there's evidence-informed interventions available, such as these three medications, they're not always widely implemented in Canada. There's a few hypotheses as to why. One is uptake of clinicians, people not being so familiar with it. That's why the CMAJ released some new guidelines, I think it was last year, on alcohol use disorder. We actually had a wonderful presentation on that previously. I think Evan Wood was one of the main authors on that. Part of it could be structural problems, stigma, lack of access to healthcare, lack of access to medications themselves. So, we don't have a good national statistic on how much alcohol use disorder medication is being prescribed and the uptake. But some of the ones that I did look at said that, in cases like Manitoba or Ontario, less than 2% of eligible patients receive evidence-based alcohol pharmacotherapies. So we only have 3 medications, and of those 3 medications, adherence is a mixed bag. Part of the other background is in the context of this only having these three medications, I became interested after listening to this ASAM podcast, episode 39 with Joji Suzuki, a physician researcher from the States. And it was looking at a recent review that was kind of reviewed 4 different studies. This is from 2024. This generated interest based on some of the signals for alcohol and tobacco in specifically like type 2 diabetic clients and those with metabolic disorders. Like I already mentioned, there's been quite a bit of buzz in the media and on podcasts and other areas around the use of GLP-1s and sort of looking at the satiation mechanisms of them, specifically eating disorders, substance use disorders. So what we're seeing is the GLP-1 system is emerging as a potential novel pharmacotherapeutic target for alcohol. I think there's a couple right now for opioid use disorder, although not very large population sizes. Tobacco is also being looked at currently. And just for context, like I did this as a AMCT, like lunch and learn during one of my rotations, I think in November. And since then, there's already been 2 different RCTs that were released. So there's more coming out as we speak. So that's why I thought it was a good subject for what's new and emerging. So GLP-1s, what does that mean? So GLP-1 is a gut hormone that stimulates insulin secretion after eating. So we eat, it promotes insulin secretion, which can lead to satiation or a feeling of fullness. It also helps to regulate blood sugar, reduces hunger cravings. The semaglutide and other GLP-1 agonists, these are these medications that bind to the GLP-1 receptors, mimic their effects, are currently used as treatments for diabetes and obesity. At least those are the sort of approved, but we are seeing people being used, they're being used off-label. So GLP is a glucagon-like peptide, which I mentioned is a gut hormone. For the receptors that we're speaking of, the glucagon-like peptide receptor, glucagon is one of these hormones from the pancreas that stimulates blood sugar. And these receptors are found throughout various body tissues. See the pancreas, where they modulate insulin. Interestingly enough, the other two major areas is in the gut and in the brain. So the more interesting, I think, the last few years has been understanding how these brain receptors, the GLP-1 receptors in the brain, are interacting. And this is where it kind of gets a bit more interesting. We begin to get into this level of connecting sort of the craving, satiation, and substance use components. So a lot of this kind of came out of several examples of animal studies. I think I have it there listed: Chong, al, and Pearden. So these folks, they did several rodent studies that demonstrated that GLP-1 receptor agonists suppressed the rewarding effects of alcohol and reduced alcohol consumption. They tested the effects of semaglutide on binge-like and dependence-induced alcohol drinking in male and female rats, as well as the acute effects of the medication on what they call the spontaneous inhibitory postsynaptic currents. So essentially, that's a big fancy word to say the ways of sort of down-regulating some of these craving mechanisms in the brain. Interestingly enough, in the rodent models, the GLP-1s, they were dose dependent. So the binge-like association patterns with the mice was dose dependent. And a similar effect was observed on the intake of other caloric and non-caloric solutions. So these are kind of the precursors that made start thinking that we should try this in humans as well. I already spoke about some of the population level signals and anecdotal reports correlating GLP-1s and substance use disorder, specifically alcohol use disorder. So a lot of these characteristics have led people and researchers to be a bit more curious about it. Semaglutide is a promising candidate for preclinical investigation, excuse me, and the need for sort of clinical translational studies. So what is it doing when we take it? So there isn't a definitive mechanism of action, but we do have some plausible neurobiological mechanisms underlying GLP-1 effects on substance use. So the GLP-1 receptors are present in the brain, like I mentioned before, as well as the gut. We notice that these GLP-1 receptors are present in brain regions associated with reward and addiction pathways. So activation of these receptors by GLP-1 medications may reduce dopamine signaling, and it could potentially reduce the reinforcing effects of addictive substances. And there's another sort of hypothesis that low levels of GABA in the prefrontal cortex are associated with poor impulse control, disinhibition, and decreased executive functioning, which are common characteristics of substance use disorders. It says addiction on there. I don't like that word. I didn't have a chance to change that. So the specific area that we're talking about in the brain, or one of the areas for the dopaminergic reward pathway, is the nucleus accumbens. I'm not going to get into deep neurobiology around this because I'm no expert, and that's a whole other talk. What we do also know is that the mesolimbic system is also part of the areas that regulate with the GABA. So the GLP-1 receptors modulate GABA in the mesolimbic system, and dopamine release in the ventral tegmental area. So that involves part of your amygdala in some of those areas. Those areas, if you're not familiar with, are kind of linked together with actions, memory, emotions. So the hypothesis that we're working with nowadays is that these sort of areas of the amygdala and the ventral tegmental area are what form these associations with craving, and then later with substance use disorders, where I'm having both memories and emotions that are triggering cravings and dopaminergic pathways. There's also another interesting bit of research in rodent studies that the GLP-1 receptors also mediate stress responses. So it could be another mechanism by which the semaglutide buffers stress-related overeating and alcohol consumption, though it's a pretty flimsy hypothesis at this point. But we do know that dysregulation in the mesolimbic pathways, so abnormal activity in the amygdala, is implicated in conditions like addiction, depression, anxiety disorders, and that's all I really want to say about that right now. I don't want to get too deep into it. There's an aspect of distorted reward processing that can be a component. And since the amygdala is primarily responsible for processing rewards and pleasure, it is a reasonable target for trying to reduce some of the behavioral aspects with substance use disorder, to put it mildly. So some of the literature that I looked at after listening to Joji Suzuki was specifically the review that he co-authored. Most of the studies that have been done are on older generation GLP-1, so like exenatide, luridagine, I think the other one's called. And we're just starting to see sort of newer ones coming out related to the next generations, like the Wegovy's and the Ozempics. So Shen et al., this was the one that was mentioned in the ASAM podcast, did a scoping review in 2024, which were lukewarm. The results of this scoping review, as they said, were mixed. They had 3 studies demonstrating positive results and 2 studies finding no efficacy of the medication on substance use disorder outcomes. So very concrete evidence. And they said it right in the review that, it's premature to prescribe this medication off-label to patients, although anecdotally it is happening. Obviously, they said there's further research is needed to determine the efficacy of GLP-1 agonists in treating substance use disorder. One of the RCTs that was reviewed in that larger scoping review was this one, 2022, by Clausen et al. And they did theirs with a population of 127 patients. This one did not show a significant reduction in daily drinks after 26 weeks with exenatide. So they evaluated the effects of GLP-1 agonist medications in alcohol use disorder and with the first generation. They did, interestingly enough, though, although the exenatide did not significantly reduce the number of heavy drinking days compared with placebo, it did give a wealth of fMRI data, which led sort of piggyback to some other interesting studies since then around this sort of attenuated alcohol cue reactivity in those sort of components of the brain of the reward system, so the ventral tegmental area. And kind of laid the groundwork for some of this more dedicated research around what GLP-1s are doing in the brain, specifically around drug reward and craving. So although it didn't affect the heavy drinking days, it did lead down the road to some interesting brain imaging. They did also actually, in an exploratory analysis, find that the exenatide significantly reduced heavy drinking days and total alcohol intake in a specific subgroup of obese patients. These are people, their BMI was like greater than 30 kilograms per meter squared. What that has for meaning is just that part of the people that they had in the study were sort of like at a moderate level for obesity, and the other folks were sort of significantly obese. A interesting article from JAMA Psychiatry, which was originally published in 2024 and then published again just recently in 2025, from Sweden, had a much larger population size. This was not a research trial. This was an observational study. And yeah, it examined patient charts of like over 200,000 individuals with alcohol use disorder and type 2 diabetes or obesity. The gist of what they found was that semaglutide and liraglutide may be effective in the treatment of alcohol use disorder, and clinical trials are urgently needed to confirm these findings. So there are more and more calls for research to be done. This was done with, this was from 2006 to 2023. And although they did two with semaglutide and liraglutide. The liraglutide was predominantly what they were referencing in this article. But once again, they didn't necessarily come to any strong conclusions. So up until 2-3 months ago, this was kind of where we were at. Whereas February, yeah, as I was preparing this presentation, I went back and lo and behold, an RCT out of the States was published in February. And this was looking at once weekly semaglutide in adults with alcohol use disorder. This came out of Chapel Hill in North Carolina. It was a pretty modest sample size. It was like 48 participants. So it's like an early phase 2 human laboratory trial. But it was using a randomized placebo-controlled dose-ranging design, which I'll show on the next slide, to investigate the effects of semaglutide on laboratory alcohol responses to consumption. So essentially they got folks into the study, they gave them once weekly semaglutide, and then they had them come back in and gave them access to alcoholic drink of their choice, and then monitored essentially how much consumption they were doing in the lab. So it's, I mean, there are some limitations to this design, but it's, I think, the most recent one that we have so far. Yeah, what else can I say about this? They also looked at not only the naturalistic alcohol consumption, but also cigarette consumption. And they're also looking at weight loss in smokers. So they were trying to kind of catch a bunch of data around it. As I said, participants had weekly visits with a dose-dependent increased GLP-1 administration. So they got, I think it was Ozempic, started them off at 0.25 milligrams and slowly increased them up to 1 milligram over a period of about 10 weeks. These were subcutaneous injections. And to my knowledge, this wasn't done with any other adjuvant treatments. So I don't think they were getting like manualized therapy. I don't think they were getting groups, anything like that. It was simply just subcutaneous injections of Ozempic. This was, yeah, Hendershot et al. Out of Chapel Hill. I think the reference is there. So what they found was the population was actually surprisingly more women than men. It's 34 women, 14 men. Mean age was 39 years old, and they gave them, split it down the middle. So 24 got semaglutide, 24 got placebo. And they found that the estimated alcohol consumed over like 2 hours during a laboratory self-administration, measured through peak breath concentrations. Sorry, I gotta move my screen here so I can see the findings. As you can see, among participants consuming alcohol in a laboratory session following 8 weeks of treatment, those in the semaglutide group drank significantly less alcohol than those in the placebo group. So an interesting outcome that is pointing towards perhaps further research needed. That's all I really wanted to speak on that one. There has been some discussions also in the internet sphere around the risks of GLP-1s, not specifically for alcohol use disorder, but for a lot of people using Ozempic. There's been concerns about people having sort of rebound weight gain when they quit Ozempic. There's been discussions and concerns about it triggering depression and suicidality. So I did a sort of cursory look to see if there's been any examinations of that. A systematic review published this year in JAMA Psychiatry looked at 144 RCTs that have been done, I think, in the past 10 years. And what they came to the conclusion was that semaglutides do not increase suicide-related adverse effects in adults with diabetes or obesity. And it found no significant difference in suicide-related events between placebo groups and GLP-1 or semaglutide users. Another interesting large data set that came up with a bunch of different things actually was looking from the Veterans Affairs in the United States. And so they pulled a whole bunch of data from the VA registries, and they looked at around like 175 different health outcomes in diabetic patients, specifically in those either using traditional diabetic medications or sort of GLP-1s. They found some positive signals for reduced inflammation, a reduction in inflammation, I should say, heart disease, weight loss, and diabetes, of course. Those are the main two mechanisms that they're known to. But they also found some interesting like neuroprotective mechanisms that aren't quite yet understood for Alzheimer's and possibly dementia. So I think there's a need for some reexamination of that data that they're looking at doing now. From what I was reading, the hypothesis is that if it does infect some of the inflammatory pathways, if it leads to a reduction in obesity and some of the other protective mechanisms around that, that could lead to a decreased risk of cognitive decline from vascular issues in the brain. The study also confirmed past research findings detailing that drugs' potential to lower the risk of heart attack, stroke, and other cardiovascular concerns, likely related to some of the metabolic pathways. They also didn't support any associations between GLP-1 use, adults with diabetes, and increased risk of adverse psychiatric events. So they didn't find any risk of increased depression, suicidality, or self-harm. So I think the larger question, however, is, those who are not diabetic or obese, all of these studies have been done under the sort of umbrella of folks with metabolic disorders, and Ozempic being sort of prescribed use for that. The one thing I didn't see anywhere was I saw most of the exclusion criteria were people with a low BMI, so people that weren't obese, obviously. And I think that's, for me, one of the next biggest questions is, if we're going to try to use these as an adjunct for alcohol use disorder or some of these other sort of eating disorders or any of these mechanisms of craving, understanding if these are only going to be indicated for folks with a high BMI and diabetes, or is there a potential for using it in other populations? The jury's still out on that one. So, as I previously mentioned, we have 1 or 2 RCTs that are fresh out of the gates that show some positive signals. There's a bunch currently underway. I think there's a lot more research to be given still. Despite that, though, there is a lot of buzz. There's a lot of buzz in the media. There's a lot of buzz even with patients. I find that now in an outpatient setting, I have older clients that are put on Ozempic for their diabetes or their obesity, anecdotally reporting that they have less cues for craving. And then I have people asking if they should be put on Ozempic. So I think there's a lot of discussion around it, whether it's valid or not. I think my conclusion is Ozempic is a useful medication. I think it is helpful, but I also think there's major issues. One with access. It's very expensive, very expensive. We don't have enough data in terms of populations that aren't obese or dealing with type 2 diabetes. There's been some concerns at different points with access in the current uncertainty of global markets. I think that's going to be continued. And I also worry in some ways around just how the media influences clients. How the media can influence clients' desires to potentially chase after fads. Maybe you folks don't see it too much in the inpatient setting, but I see it quite a bit in the outpatient setting, especially with alcohol use disorder. I saw quite a bit of discussion around people wanting to be put on Ozempic when I was in some of the private treatment centers. And so that was also what sparked some of my interest around that. Beyond that, my biggest discussion question is for those that are prescribing, how do you feel about Ozempic? How do you feel about Wegovy? What kind of conversations are you having with clients? Is it a conversation that you're having with clients? And if you are having those patients that are diabetic, that do have metabolic disorders, is this a medication that you're considering? Is it not? I can send my references here.
Thanks so much, Adam. What an interesting presentation and a comprehensive overview of what there is so far, and like very much a what's new, true to the name of something.
Sorry, I ran through it a little bit quickly. My
quite novel. No, this is that was a great pace. So Amir, I don't know if folks can like unmute themselves and talk at all in this particular format of Zoom, but I would just want to encourage folks to use the chat function if you would like to put any questions or comments in for Adam, your own questions and comments, or potentially anything related to these discussion questions he has posted here. How much does it cost, Adam? I'm curious about that since you mentioned that. Do you know what the costs are?
Well, off the top of my head, that's not something I do have, but I can do very quickly.
Yeah. But just sort of, yeah, when we think about access, someone requesting it. Yeah, I was just kind of curious about what that cost is and what coverage there might be if folks were interested.
So what I have is about $200 to $300 per month.
Okay.
That's what I'm seeing here. Yeah,
Yeah.
that's
Okay.
that's what I'm looking at. I'm looking at a couple. I'm looking at NovoCare, and then a CBC article,
Okay.
and then one more. So it looks like you're looking at about $200 to $300 a month.
Yeah. Okay.
Yeah, I think like I said, the interesting thing for me was just how much it's rare to see a medication get this much celebrity status, whether it be on podcasts, Dr. Oz, whatever. And originally it was just for the idea of weight loss, right? That's what most people know it is. But I would say in the last 6 to 8 months, I've seen an increasing discussion around it being used for eating disorders and for substance use. And when that starts to generate, I think, some general interest from the population, being able to discuss or have that conversation is important, because I had really no knowledge of it myself until I sort of did a deep dive and said, oh, actually, no, there's maybe some indications here in how it interacts in the brain neurochemistry.
Yeah, I wonder, yeah, because I mean, in the substance use field, I feel like there can be a lot of stigma around medications, and people are hesitant to take medications to treat. I mean, it extends to mental health too, right? It's like, there can be a lot of ambivalence and there can be stigma around taking something because it's like really acknowledging that that is a significant challenge for you.
Yeah.
And so it's interesting, and maybe even just that attention maybe is a positive thing overall, that people are in, like, not that there's like, oh, there's this miracle thing that can, like, fix all of my problems, but that there's like interest in something that could support people's well-being. Because you could also, if someone brings it up to you, you could also be like, okay, you're interested in this, like, and then potentially shift the conversation to some of our more established treatments that they could potentially try first, knowing that, there's still work being done on the evidence. So maybe it actually will, bring up the conversation more for people who may never ask their care provider about a medication or a treatment, because I mean, again, very poorly, our current treatments for AUD are so poorly integrated into primary care and just into the general awareness that there are medications that people can take for alcohol use disorder, whether they drink every day or not. I think a lot of people don't know that, but yeah, maybe it'll open up some good conversations too, that maybe eventually lead people to getting some support that can be beneficial for them.
Yeah, I mean, I think the big things that and if anybody wants, just feel to chime in. Like I'm very, we can just gab about this if people have any thoughts about it. But I think the thing that I've noticed, at least in my practice, is a lot of people relate to naltrexone, and whether they're educated or not, people get naltrexone and naloxone confused. So there's hesitancy around that, especially with people with alcohol use disorder. I've encountered people, when they start hearing that naltrexone works on some of the opioid pathways, they hear opioid and they just automatically start going down that field. Where the interesting thing I've seen with the whole Ozempic miracle drug phenomenon is, of course, it's not a miracle drug, but I have more people asking about it because the way the media has spun it, it's spun in a very different way than, say, a camprosate naltrexone.
Folks I guess it's a little harder for folks to chime in this format. So people, there's a few things in the
Well,
chat. I don't know if you can see it, but
yeah,
Crystal
I'm curious.
message. So in their program, there's a client with significant weight gain and metabolic syndrome related to their antipsychotic prescriptions. So they've been prescribed Ozempic, although waiting for special authority approval for coverage. And they're looking forward to seeing if there's any significant or any influence on her significant polysubstance use disorders in the coming months. So yeah. That's,
Cool.
that's an
Very cool.
interesting hearing how it might be used in some really different contexts and even to treat something that's actually being, caused by a treatment too. And then Andrew messaged, given the cost and that there isn't the solid evidence base as a first line treatment and compounded with the hype, it sounds like it may be used more in the private treatment sector first, then depending on benefits or adverse event effects that may trickle down. And then I remember there being shortages when the hype really ramped up, which would be concerning or destabilizing if it was being used as an AUD treatment. Yeah, shortages are like a pretty big deal if you're starting to
Totally.
promote something and people, need it for maintaining their well-being.
And that's such a good point, Andrew, because that was also something that I was encountering, like I said, as I rotated through some of these private treatment centers, where there's just a different approach than say what we're doing in the for-profit sector, where it's like it becomes a what do you want? Sure, you want this, you want that. What do you want to get on testosterone, and all the things. And it was intriguing to me once again to sort of see this. Okay, are we seeing this sort of two-tier system where if you can pay, you can get access to whatever, even if it's an off-label use, versus if I go to my family doctor and say, hey doc, I'm struggling with alcohol use disorder, and all I really get is the acamprosate and naltrexone. And part of the reason I picked this too was very much because of this component of hype. And I think in general, everybody can argue or not that we're dealing with an era where science doesn't always speak the loudest in the room when it comes to what shapes public opinion. And so looking at some of these things, I think was another intriguing aspect of the question for me. It's like, okay, like everybody's talking about this, what, is it safe? Is it effective? Well, yeah, thanks for those points, Andrew. And Crystal, yeah, I'm intrigued to see what happens with that individual.
And it's promising to hear that. Sorry, go ahead.
I was gonna say the one thing that when I did a cursory dive into all of this was I haven't found anybody looking at either. There were some folks looking at doing like a micro dosing versus a therapeutic dose of GLP-1s, but I didn't see any actual examination of can this be, if we are going to look at using this in the context of addiction treatment or substance use disorder, can this be administered to folks that have a normal BMI, that don't have diabetes, that don't have obesity, and is that going to cook their pancreas? Is that going to cause negative outcomes? I don't know why my hand's raised.
It's an automatic function if you move your hand, which you did, and then it just did it for you. So yeah. Yeah, very interesting. And I think, hopefully there's a way to look at outcomes for folks who are prescribed it potentially in some of these other settings or in private treatment settings to sort of, yeah, evaluate that, given there's not a ton of evidence yet. And we have really good evidence for what we have, but folks aren't as interested in it. So that's a gap. Yeah.
Yeah, I encounter that a lot. I mean, and actually it's even interesting with the acamprosate and naltrexone is, I encounter folks that do really well on naltrexone, and then, their neighbor takes it and they're nauseous and they feel terrible, but then they do fine with acamprosate. And I guess the trickiest thing, at least in my practice, where I'm dealing with folks that are dealing with a lot of like intersectional layers and barriers to access, to even consider taking a medication. We really want to make sure it works.
Yeah.
And that it's easy for them to follow. And I don't know if an injection of a GLP-1 would make the most sense in that population, particularly sort of in remote communities. But I have had, like, I can think of at least anecdotally 7 elders, they've been put on, they've been put on Wegovy. And I think it's a combination of other things, but their alcohol use consumption decreased. Their, their weight loss stabilized. It's I can't say that that's the only thing, but I think as an adjuvant treatment, it's interesting to consider in those people that are already maybe going to be on it. Like, okay,
Yeah.
will this maybe help? If we're already going to have to put you on, some kind of diabetic medication, and you have an alcohol use disorder, can we maybe do two birds with one stone here?
Yeah.
If it's covered and everything else.
Yeah,
Right?
exactly. Yeah. And perhaps is easier than, other medication delivery systems or strategies for people.
Yeah.
Yeah.
I mean, full disclosure, like I'm also interested in looking at anything outside of the box that we can potentially look at as value. I mean, my journal club article was on psilocybin use and alcohol use disorder. So, I mean,
Yeah.
I think we're at a point where we have to start looking at all the options in a safe and reasonable way.
Yeah. And I think more options are always better for people as long as they are safe and effective. And just the stats you shared at the beginning certainly highlight the importance of like really continuing to focus on how to support people with alcohol use disorder, given that huge burden and impact for people's health and well-being.
Well, I don't really have any other comments or thoughts. Thanks everyone for showing up for lunch. Sorry we didn't get a lunch together. I'm recovering over here, so I'm just taking it easy. Otherwise, I would have been there in person.
Well, thanks, Adam, and thanks, folks, for joining and your questions. And I think Amir will pop a evaluation into the chat if it's not already there, just to get you to let us know how these presentations are going. And yeah, we really appreciate your input and time. And thanks again, Adam, for a really interesting overview of this emerging novel treatment.
Yeah, there'll definitely be a lot more coming out, so stay tuned. I have a lot of research trials happening, and I think there's, for better or for worse in the pharmaceutical industry, when they feel like they have a hit, they want to see how many things they can cover with it. So that's a whole other conversation.
All right. There's your evaluation link. Thanks, Amir. And again, thank you, everyone. And yeah, take care this week.